All right, here we go, wonderful students. Comfort and pain management, which is a huge component of being a great nurse, is managing your patient's pain. Patients experiencing moderate to severe pain directly limits their activity and diminishes their quality of life. Activity is important to main daily functioning, such as walking, standing, climbing a set of stairs. They're all limited when people are in pain. Pain is a stressor to the body, and the patient's response to pain limits the body's healing process and extends the healing time. This chapter discusses the pain experiences and factors that influence it. Here are the learning objectives for this chapter. Please take a moment to review each one of these. If you can speak to these and apply these to your nursing practice, then you have accomplished your learning for this chapter. Okay, so the definition of pain is literally this. Pain is whatever the patient says it is and whenever the patient says it is, okay? We cannot question if they state they're in pain because they're literally the one experiencing it. Pain is such a personal experience because it is influenced by many, many factors. Biological factors, psychological factors, psychosocial factors, physical factors. I could go on and on, okay? The biological factors associated with pain are several, including age, gender, comorbidities, possibly the patient's smoking status, whether the patient's having fatigue, if they're having sleeping problems, etc. Even physical symptoms like pain can be affected by the psychosocial influences on the patient themselves. For example, when a patient's going through a divorce, their pain threshold is much, much lower because of the additional psychosocial stress, okay? That's an important concept to get, right? Psychosocial factors that may affect pain include things like your marital status, your social support or the lack thereof, if you're going through bereavement, your home environment, right? If that's positive or negative, your work environment, if there's someone's harassing you at work or you're being attacked, those kinds of things, right? Your social status, your social integration, do you have those kinds of skills, right? Psychosocial factors that may affect pain include things like, again, your marital status. It could include things like, do you have someone you can share your thoughts with, right? So you can just, debrief at the end of the day or, just wind down. You really do need those kinds of supports, right? And there are some people out there that don't have those kinds of supports. For example, if someone's under a great amount of stress due to their family life or maybe work stress, again, they're going to have a much lower threshold for pain. Pain arising from activation of the nociceptors is called nociceptive pain. Nociceptive pain can be classified according to the tissue in which the nociception activation occurred. For example, superficial somatic would be in the skin. Deep somatic would be in your ligaments and your tendons and your muscles. Visceral would be in your internal organs. Pain and nociception are different. While nociception refers to the neural ending of actual or impending tissue damage, pain refers to the subjective experience of actual harm or the subjective experience of impending harm. The terms nociception and pain therefore should not be used synonymously, right? Because each can occur without the other. Examples of types of injury that can cause nociceptive pain include bruises, burns, cuts, fractures, pain caused by repetitive or overuse of muscles or ligaments, pain caused by joint damage like arthritis or even sprains. And remember, pain is learned through the individual's life experiences, and it is intended to be an adaptive role, right? So we learn through our pain experiences, right? And pain can be expressed in many ways, not just verbally. So we have to be always looking for all the different types of pain, not just verbal, but nonverbal, emotional, psychosocial, religious, spirituality, all of those types of pains, okay? Okay, categories of pain. We have acute pain, typically short-term pain that comes on suddenly and has a specific cause. usually tissue injury. Generally, it lasts fewer than 6 months and goes away once the underlying cause is diagnosed and treated. Acute pain tends to start out sharp or pretty intense before gradually improving. Pain that lasts for more than 6 months, even after the original injury has healed, is considered chronic pain. So an acute pain can eventually become a chronic pain if the injury heals and that person still experiences pain. And we see this many times with like back injuries, right? And as you know, that's where the nerve endings are at. So it makes sense why people who have back injuries that get surgery, sometimes, there's some pain at some level permanent wise, right? It may get a little bit better, but sometimes there's chronic pain for many people. Chronic pain, on the other hand, lasts for years and ranges from mild to severe on any given day. While past injuries or damage can cause chronic pain, sometimes there's absolutely no apparent cause. Sensory impulses convey sensations of heat, cold, pain, position, vibration. Remember from A&P, you don't need to memorize this, but have a bigger understanding. The axons enter the spinal cord by way of the posterior root, specifically in the posterior gray columns of the spinal cord, right, where they're connected with the secondary neurons. And pain and temperature fibers cross immediately to the opposite side of the cord and course all the way upward to the thalamus, right? So that's where we're getting these pain sensations from. Our spinal cord. Pain, and because they cross over all the way up to the thalamus, pain can be difficult to assess because patients can have difficulty describing it, localizing it, or the pain can be referred, right? For instance, if someone has had a surgery or has had a broken bone, it may be easy in that case to determine the cause due to the fact that we can see the source of the pain. However, many people experience pain from disease or illness, and we cannot see these areas. Patient's description of the pain may not match the actual cause of the pain either, such as many people experiencing gallbladder pain feel it in their back, between their shoulder blades. Sometimes it'll be in the right shoulder, and this again is called referred pain, right? Because it's pain being referred to a different area of the body than where it is actually being produced, right? And again, that's due to that inverted spinal segment, in the crossing of those fibers. Localization of pain is determined by whether the pain is superficial somatic, whether it's deep somatic, or whether it's visceral. Again, superficial somatic pain originates in the skin, mucous membranes, or other superficial tissues of the body. Often described as sharp or stabbing, superficial somatic pain is usually well-defined, localized to the area of the injury, and almost always is constant. Somatic pain is the type of pain you feel in your skin, your muscles, your joints, things like that. It can feel like gnawing or aching or sometimes cramping. Some people describe somatic pain as sharp, sometimes. Deep somatic pain originates from structures deep within your body, such as your joints, your bones, things like that. And then we know we have visceral pain, and visceral pain describes pain emanating from the internal thoracic or maybe the pelvic area or the abdominal organs, right? Unlike somatic pain, visceral pain is generally vague or localized, and it's characterized by like this hypersensitivity to stimulus such as organ distension. And then etiology of pain. Etiology means cause or set of causes. So the etiology of pain refers to the cause or the origin of the pain, which can be classified as one of three distinct categories. Again, we have nociceptive, and then we have neuropathic or idiopathic, right? So I've already talked about nociceptive, but neuropathic would be stemming from the nerves, right? Or the neuropathic pathways in the body. And then idiopathic literally means unknown cause at the time, right? And we may never know. but we still treat it. Okay, duration of pain. So acute pain is caused, again, by injury, surgery. We could cause it, right? Intentional, because we're going in, cutting the patient open to do surgery. Could be illness. It could be trauma. It could be painful medical procedures, right? It serves as a warning of disease. That's a critical, important concept, okay? So pain does serve the body as a warning of disease or a threat to the body. So pain is protective in nature. It generally has a rapid onset. It varies in intensity and duration, and it lasts for a short period of time. Again, usually less than 6 months, and it usually disappears when the underlying cause has been treated and the patient has healed. Acute pain usually results from a specific injury, disease, and or inflammation. Again, it usually comes on sudden, for example, after physical trauma or surgery, and can be accompanied by anxiety and emotional distress. Normally, acute pain is a protective response to the tissues being damaged resulting from injury, disease, overuse, environmental stressors, so many factors. The cause of acute pain can be diagnosed and treated typically. The pain is self-limiting, meaning it is confined to a given period of time and severity. Acute pain, however, can become chronic if once the underlying area is treated, but the pain still exists. Chronic pain is a medical disease that can be made worse by environmental and psychological, psychosocial factors. Chronic pain persists over a longer period of time, longer than 6 months, and can be challenging at times to manage. People with chronic pain often suffer from more than one painful condition. They also have an increased risk for developing problems with physical functioning, cognition, and emotional reactions, and it becomes a vicious cycle, right? So the pain causes the emotional damage, and then that will lead to some cognition decline, which leads to physical decline, which then will lead to further emotional decline, and so forth, right? There may be common mechanisms that put some people at higher risk for developing multiple pain disorders. It is not known whether these disorders share a common cause. It could be limited, intermittent, it could be chronic, persistent pain, intermittent, it could last beyond the normal healing period. Patients could have periods of remission where they're, doing really good, and then they have an exacerbation. These are common, right? An exacerbation is called breakthrough pain, so they'll have the pain come back, so it breaks through. And acute and chronic means having both types of pain simultaneously. And patients who have chronic pain, they do get injured and get acute injuries, right? Or they go under the knife and have surgery and therefore will have an acute injury, right? So our chronic pain patients are going to have acute and chronic at times at the same time, which becomes challenging to manage, right? Okay, sources of pain. Again, nociceptive is the most common type of pain. It's caused by stimulation of the nociceptors, again, which are pain receptors, and we use, it's caused by tissue injury. We have nociceptors throughout our body, especially in our skin and internal organs. When they're stimulated by potential harm, such as a cut or other injury, they send electrical signals to the brain, causing the patient to feel the pain. Visceral pain results from injuries or damage to the patient's internal organs. They will feel it in their trunk of their body, which includes their chest, abdomen, and their pelvis. For visceral pain, it's very hard to pinpoint the exact location for patients, and they'll describe it often as like pressure or aching or squeezing or cramping, something like that. Somatic pain results from stimulation of the pain receptors in your tissues rather than your internal organs. This includes your skin, muscles, joints, connective tissues, bones, those kinds of things. It's often easier to pinpoint the location of somatic pain, much more easier than visceral pain. Somatic pain usually feels like a constant aching or gnawing sensation. Then we have cutaneous pain. Cutaneous pain is also referred to as superficial pain. Usually involves the skin or subcutaneous tissue. A paper cut that produces sharp pain with a burning sensation is an example of cutaneous pain. Neuropathic pain results from damage to or dysfunction of the nervous system. This results in damage or dysfunctional nerves misfiring pain signals. The pain seems to come out of nowhere rather than, response to some type of specific injury. Neuropathic pain is described as burning, numbness, tingling, shooting pains. Paresthesia, which is that numbness and tingling, pins and needle sensation. Freezing, some patients have described it as freezing. Neuropathy is the loss of nerve sensation. Gastroparesis is the decreased nerve impulses to the gut, causing delayed gastric emptying. All right. Our unifying theory or law of pain states the following. The origin of all pain is inflammation and the inflammatory responses in the body. Biochemical mediators of inflammation include our cytokines, our neuropeptides, our growth factors, as well as our neurotransmitters. This is a little bit of review from A&P. So literally, sorry about that. Somebody knocked on my door. Okay, let's see if I can remember where I left off. I'm sorry if I repeat this. Okay, just a little bit of review from anatomy and physiology. What is pain? Okay. So pain is an unpleasant signal that something hurts, right? It's a complex experience that differs greatly from person to person, even between those with similar injuries and illnesses. So just because one patient went through a gallbladder attack, that does not mean we as nurses know how to care for the next patient that goes through that. Yes, we have some generalities and ideas of what we're going to do, but everybody experiences pain differently, and therefore will need to be treated as such. Not only that, but disease processes and things that can go wrong with each of them are so vastly different. So just because you did A, B, C, D, and E for your one gallbladder patient doesn't mean that you won't do A, B, C, D, E, F, G, H, I, J, right? Okay. Let's see. Pain can be very mild, sometimes even unnoticeable for some patients, or can be the opposite end, which is explosive and just absolutely unbearable, right? What is the difference of physical pain? It is an unpleasant feeling such as a prick, tingle, sting, burn, ache. Again, pain can be sharp or dull. It may come or go. It may be constant. Patients may feel pain in one area of the body, such as their back, abdomen, chest, pelvis, or they may feel pain all over and not be able to quantify where it's coming from, but just everywhere. Pain can be helpful in diagnosing a problem, right? Psychogenic pain is the term for pain that is primarily caused by psychological factors such as depression and anxiety. While psychogenic pain is not caused by clear physical pathology, it is a very real type of chronic pain. Physical pain has a defined source from an illness, injury, or disease, but psychogenic pain can cause pain without a physical source or it can also make pre-existing pain worse, much, much worse, or linger for a much, much longer time. It occurs when patient's pain is related to underlying psychological, emotional, or behavioral factors. Psychogenic pain can be felt all over the patient's body with varying intensity, though it most commonly presents as headaches, muscle aches, abdominal pain, or even back pain. Referred pain is pain felt in a part of the body other than where it's actually being produced. Referred pain is when the patient feels pain in one part of the body, but the real source of pain is coming from a different part of the body. One common and harmless example is brain freeze. The extreme cold touches the patient's mouth and throat because they feel the effects of it in their head. I'm sorry, but they feel the effects of it in their head. So the patient's drinking an icy, right, really fast. It touches their mouth and throat, but then they get this intense, pain in their head. That is referred pain. Intractable pain refers to a type of pain that can't be controlled with standard medical care. Intractable essentially means difficult to treat or manage. Intractable pain can develop from several types of health problems. It can be felt in patients' joints, bones, muscles, even in the head. Conditions that can cause intractable pain include migraine headaches, tension headaches. If you've ever had one, then you can relate, right? And then we have phantom pain. So what is phantom pain? Phantom pain is when a patient feels pain in a body part that they no longer have, right? Most commonly, it involves limbs that are no longer there. So limbs that have been amputated. This is specifically known as phantom limb pain. However, phantom pain is a more general condition and does not necessarily need to include limbs, right? So it could be just a phantom pain in the body. Examples of phantom pain include, when somebody has a BKA or below the knee amputation, they'll end up having phantom limb pain, foot pain that's not there. How about phantom organ pain, which occurs in organs that a surgeon has removed, such as the gallbladder? Yes, I've had a gallbladder patient who was septic and ended up in my ICU bed for a couple weeks, and she made it. And for a while after she woke up in the ICU, she had the same gallbladder pain that brought her into the hospital. So it was phantom gallbladder pain. So again, it could be teeth, it could be fingers, right? Sometimes you get a lot of phantom pain in the mouth. All right, so here's just a quick overview again. You don't need to memorize this to regurgitate it, but you need to have an understanding of it on a higher level so that you get how pain can originate from different parts of the body. So we have transduction is the activation of our pain receptors. It involves conversion of painful stimuli into electrical impulses that travel from the periphery to the spinal cord. And then the transmission is the process of these pain sensations from the site of an injury or inflammation, and then they're conducted along the pathway to the spinal cord and then up toward the higher centers. The perception of pain involves the sensory process that occurs when a stimulus for pain is present. It includes the person's interpretation of the pain. Again, pain is a very personal experience that varies from person to person. What feels very painful to one person may only feel like mild pain to another. And there are other factors like emotional state, physical health. They all play a big role in how the patient feels that specific pain episode. The process by which the sensation of pain is inhibited or modified is referred to as modulation. Probably sounding familiar from A&P, right? The sensation of pain appears to be regulated or modified by our neuromodulators. That's what they're there for, right? And these neuromodulators are indigenous opioid compounds, meaning they are naturally present in our body. Morphine-like chemical regulators in the spinal cord and in the brain. Ding, ding, ding. Makes sense, right? And they appear to have analgesic activity, and they alter the perception of pain, right? So we have our body's self-protective measures going on there, right? To try to give that morphine-like chemical modulator reaction so that it can the patient doesn't have to experience the pain to the intensity or level that it is actually occurring. Pain stimulators again, this slide talks about stimulation of the nociceptors and pain receptors. You don't need to memorize this, but you should have a good understanding, a bigger understanding of it. Okay, so again, pain stimulators such as bradykinin, prostaglandins, substance P, they all work together in the pain process, right? These mediators are released upon tissue injury and are very important mediators in inflammation and pain. Bradykinin is a very powerful vasodilator, right? And it increases capillary permeability and constricts smooth muscle. Then we have prostaglandin. It's an important hormone-like substance that sends additional pain stimuli to the central nervous system. Substance P is receptors on nerves that helps feel pain, so it sensitizes those receptors on nerves, and it helps feel the pain, and it also increases the rate of the firing of the nerves, right? Probably one that you should know is our mu receptors. Mu receptors, they are in the central nervous system, and that's what perceives pain, right? It is at these sites where our medications take up to reduce the sensation of pain. Okay. Gate theory. So this is important to know so that you can, when you're treating pain, you understand all of the factors that's relevant to how patients perceive that pain. So the gate control theory is a practical model to explain the concept of pain. The way in which people experience pain is very complex. All sorts of factors influence a patient's experience, including their thoughts and feelings. For example, even though a person is in pain, they are only dimly aware of it. This can happen, for example, when a patient is really engrossed or distracted by something interesting or having to face a situation which demands a lot of their attention. On the other hand, some situations make one more aware or more focused on how much pain they can feel. The more we think about our pain, the worse it can feel. In the spinal cord, imagine a series. This is what I want you to imagine, okay? Excuse me. In the spinal cord, imagine a series of gates in which messages about pain arrive from all over the body. These gates can sometimes be much more open than at other times. This is important because it is through these gates that messages from the body pass toward the brain, right? If the gates are more open, then a lot of pain messages pass through to the brain, and the person is likely to experience a high level of pain. However, if the gates are more closed, then fewer messages get through, and the person is likely to experience less pain. Things that can make the gate more open are stress, tension, emotional states. They all play a big role in how a patient perceives pains. Mental factors also, staying focused on the pain is not good. Lack of activity, not good. So sitting in a hospital all day, looking at four walls can really make someone's pain much, much worse. Factors that can contribute to closing the gates and making pain less noticeable or less severe are relaxation, contentment, mental factors, nurses using distraction like TV, music, reading a book, right? All of these activities, taking them to the activity room, moving, doing something, redirect their focus, right? And then, of course, other factors that can close the gate is medications, maybe massage, heat therapy, ice therapy, mindfulness, all of the things that Marcel talked about or is going to talk about in class this next week. The perception of pain involves the sensory process that occurs when a stimulus for pain is present. It includes the person's interpretation of the pain. Remember, a patient's pain is whatever they say it is, whenever they say it is. Perception of pain differs from individuals, and the way an individual's body modulates pain is specific to that person. This is why many people feel pain differently. Mediators and chemical reactions all happen differently in different people's bodies. Other factors of modulation or reaction to pain are the health of that person's body at the time, their psychosocial state as well. Individuals can adapt to pain as well in the case of people who live with chronic pain, right? So people who live with chronic pain tend to have a higher threshold of pain because they've been dealing with it for a long, long time. They've also adapted to the pain, right? And they continue to participate in their activities of daily living, even though they're having chronic pain, right? Patients who live with chronic pain will tell you they live at a pain level of 5 out of 10. And yet, look as though they are in no pain at all. That's another, excuse me, I get the hiccups. That's another important concept to get. So chronic pain patients will, because they've been dealing with it for a long, long time, right? Much longer, like longer than 6 months, right? They will look like they have no pain, but tell you they're a 5 out of 10 because they've dealt with it for so long that it's become, unfortunately, part of their daily life. Pain sensation and relief. So pain's path begins as a message and is received by our nerve endings. So let's say, for example, you burn your finger, like the lady in the picture, right? The pain signal from the burned finger travels as an electrical chemical impulse along the length of the nerve to the dorsal horn of the spinal cord. Again, remember that runs the full length of the spine all the way up to the hypothalamus, and it sends signals from all over the body. So this message is relayed to the thalamus, in the brain, right? A sensory center in the brain where sensations such as heat, cold, pain, touch, all of those, right, are they first become conscious in our thalamus. And then it travels on to the cortex where the intensity and location of pain are perceived. So notice that, right? So initial recognition of it happens in the thalamus, and then it travels to a different part of the brain where the intensity and location of pain are perceived, and that's in the cortex. Pain relief begins as a signal from the brain, and it descends by way of the spinal cord. In the dorsal horn, chemicals such as endorphins are released to diminish the pain message from the injured burned finger. So there you go. Common responses to pain. So we have physiologic responses to pain are mainly aspects of the body's integrated defense responses, including our sympathetic nervous system, fight or flight, right? Remember the sympathetic nervous system from anatomy and physiology? You will need to bring that information forward. You have your sympathetic, your fight or flight, and your parasympathetic, which is your rest and digest systems, right? So again, make sure you bring forward that information from anatomy and physiology, your sympathetic nervous system, fight or flight, and your parasympathetic nervous system, rest and digest. So your physiological responses to pain are completely involuntary. However, your behavioral responses to pain are voluntary, and affective responses to pain are psychological. Behavioral responses to pain can be verbal. For example, you may have verbal descriptions of the intensity, the location, the quality of the pain. You might have vocalizations of distress, moaning, complaining. And then we have nonverbal, which is like withdrawing from activities, taking pain medications, or pain-related body postures. You might have a patient, your facial expressions like frowning or furrowing of their brow, right? Where they're like, they got their forehead scrunched in and they're literally furrowing their brow, right? Behavioral or voluntary pain behaviors can be verbal descriptions of the intensity, again, location, quality. And then some examples may include crying, guarding. Affective or psychological parts of the affective dimension of pain is the moment by moment unpleasantness of pain. And it may be it's made up of emotional feelings that pertain to the present, or the present future of the pain, or the short-term future. It could be distress, it could be fear. But again, you have the affective with an A, psychological dimensions of pain. It could, in examples of affective, could be stoic behavior, or it could be hysterics. It could be lashing out at others because of the affective response, right? So again, affective motivational dimension is like the unpleasantness, or giving the label affective captures how bad or how unpleasant the pain really is, right? And it captures the motivational aspect of pain, meaning it makes us take a protective action. And again, could be examples like your patient being very stoic, or being upset at everybody on the floor because nobody's helping manage their pain, right? And then we have psychogenic pain. It's the term for pain that is primarily caused by psychological factors such as depression and anxiety. And while there isn't a clear physical pathology with psychogenic pain, it is a very real type of chronic pain. Headache, backache, stomach aches, they're all the most common types of psychogenic pain, and it is something we have to deal with and treat. And it is commonly accompanied by social rejection, broken heart, grief, regret, lots of emotional events with psychogenic pain. There must be an appreciation that each patient's response to pain is based on a host of experiences and factors, and therefore requires an individualized plan of care, right? For example, one patient may present with a calm, objective, matter-of-fact approach to pain, while another patient may present with loud vocalizations, an emphasis on their unique experience, physical movements, demands for relief. Both of these patients are experiencing pain. It is particularly important to avoid stereotyping responses to pain because the nurse frequently encounters patients who are either in pain or anticipating that pain's going to develop, right? A form of pain expression that is frowned on in one culture may be desirable in another culture. So yes, culture is going to be a huge component of pain, right? For example, enduring pain stoically is a sign of strength among some groups. Other cultural related variables are family, sex, gender, age. A person's response to pain or symptoms may be affected or influenced by the response of family members. Some religious beliefs can be a very powerful influence on how a patient perceives pain. In some religions, people view pain and suffering as a lack of goodness in themselves. Thus, pain and suffering are viewed as a means of purification or making up for our sin, our individual sin. This meaning helps the person to cope with pain, thus becoming a source of strength many times. A person's environment and the presence or absence of caring, supportive people may also influence the experience of that pain episode. And it's important to know, how does culture influence the perception of pain? Again, this depends on factors such as whether their culture values pain, displaying emotions, or whether the culture disvalues the displaying of any emotions. Some cultural groups expect an extravagant display of emotions in the presence of pain, while others value being stoic, right? And being restrained and put together, right? And playing down pain. For example, American Indians, Asians, Blacks, and Hispanics are very stoic regarding pain and may maintain a neutral facial expression despite being in severe pain. So it's important to know that, because as nurses, we need to make sure we are always taking what the patient says as far as pain is concerned, but knowing that if they're being stoic, we may not physically see exactly how much pain they're enduring, right? Some religions may believe pain is part of God's plan, a test of faith, or a pretense for past sins. Hispanic communities hold beliefs about pain and pain medications that contribute to some disparities, including fear of addiction, stoicism that we already discussed. They do like or have a preference many times for some remedies that have worked with their culture. And some religious beliefs that it's, God's will, right? In contemporary Anglo-European cultures, they tend to express pain to get it out by sharing it with others. And then Confucian cultures, which cover much of Southeast Asia, tend to advocate that people should keep their pain to themselves. See what other cultural. It was found that African Americans have a significantly lower pain tolerance than both Asians and Caucasians. Asians have a higher pain intensity than most. And Asians, ironically, also reported the highest pain threshold compared to all groups. Again, religion and pain. How does spiritual beliefs influence pain? Well, they do for some patients. For some patients, trust in God, a conscious and healthy way of living, as well as having a positive attitude are all found to be effective ways of dealing with pain. Individuals who are associated with spiritual activity have a higher level of pain tolerance, and a higher level of psychological well-being. Hinduism encourages the acceptance of pain and suffering as part of the consequences of karma. It is not seen as a punishment, but more as a natural consequence of past negative behavior, and is often seen as an opportunity to progress spiritually, right? So it's looked upon as a positive thing. Christians, how do Christians view pain? During times of suffering, Christians believe we experience God at a deep, profound level. Suffering equips Christians to comfort others. It gives Christians a compassion for others who are hurting. It enables them to minister more effectively. One of the core beliefs of Muslims infers that illness, pain, and dying may be a test from God. They also believe that any unforeseen hardship is a test by which one's sins are washed away. And how does an environment influence pain? Pain can be affected by other illnesses, by environmental factors such as temperature, for example. So things like that, right? Lowering the temperature in the room or raising the temperature in the room can help or hinder your patient's management of their pain, right? Living with pain and coping with daily life can be tiring. And many people that talk about fatigue are dealing with chronic pain, right? Excuse me. Getting to sleep and being disturbed at night were big issues for people who have chronic pain, right? Individuals with chronic pain report high levels of social support. So people, let me start that sentence over. Holy smokes. People who have chronic pain, but also have high levels of social support, they actually report less distress and less severe pain because of the higher level of support. So you can see how by emotionally being supported and having an outlet, that will help lower someone's pain level, their perception of that pain level, right? Anxiety is known to make people suffering from pain even more hypersensitive to that pain, which makes them focus on it, right? Which is going to just exacerbate it and make it worse. This combination leads to more problems because focusing on pain only makes it much, much worse. Anxiety alone creates its own kind of pain that can also contribute to its own chronic pain problems. So again, remember, stress modulates pain perception, resulting in either stress-induced analgesia or stress-induced hyperanalgesia. So it either makes it worse or makes it better, right? So the responses to stress, again, remember, include your neural, endocrine, behavioral changes, right? Your coping strategies, all of these things that are put in place to address stressors in your life and environment. Other things that can affect pain include poor past experiences where pain wasn't managed could definitely affect the patient's current pain experience. And we need to remember that, right? If they come in and everything that's on their mind is how poorly and how much pain they were before, then that is going to affect this current hospital stay. So be aware of that, right? Past experiences can affect current pain experiences and their sensitivity level, right? All right. Okay, general assessments of pain. Again, we have 4 major types of pain, right? Nociceptive pain, result of tissue injury. We have inflammatory pain, right, which is an abnormal inflammation caused by an inappropriate response by the body's immune system. We have neuropathic pain, which is caused by nerve irritation. And then we have functional pain, which is pain without an obvious origin, but can cause pain. Because the pain experience is unique to each person, the nurse who wants to help the patient achieve comfort and pain control needs sophisticated pain assessment skills, assessing all factors that affect the pain, including psychological, emotional, social, cultural, spiritual, all of those, right? As well as physiological, are essential. Pain is complex and difficult to interpret and requires a reliable assessment skill. This slide lists the assessment criteria for assessing a patient's pain. Remember, pain is considered the 5th vital sign, and we get it every time we do vitals, okay? That's how important it is to us. Be sure you are assessing your patient's pain frequently. Generally, I will assess my patient's pain on a pain medication parameters. If the doctor has ordered pain medication every 4 hours, be sure you are assessing their pain at least every 4 hours. I assess it way more frequently than that, okay, every 2-ish hours. Duration, pain onset, length of time, when did the pain start, how did it start, how long does it last, what makes it better, what makes it worse, localization of the pain, is it localized, is it superficial somatic, is it visceral, is it deep somatic? Then we move on to quantity and intensity of pain. So measurement by subjective report is by far the most common type of procedure for quantifying a patient's pain. Patients may indicate pain levels verbally. They may mark simple scales, or they could fill out complex questionnaires. How bad, for example, asking your patient, how bad is your pain on a scale from 1 to 10 or 0 to 10, where 1 is the minorest amount of pain, like stubbing your toe, and 10 is the worst pain of your life, right? Quality of pain refers to the pain's nature or quality. Healthcare providers may ask patients to describe their pain in their own words. For example, the patient may describe their pain as sharp, dull, throbbing, burning, right? What does the pain feel like? Note, if the client struggles to answer this question, you can provide suggestions such as aching, stabbing, burning. Next is chronology of pain. This is the history of the pain from the beginning. Okay, so the very beginning. What were you doing when you experienced this pain, right? Those kinds of things. Severity of pain. So we have, again, scales that we're going to talk about in the next couple slides, where your patient will rate their severity of pain. And that's the pain intensity, right? Using some type of scale, whether it's a numbered scale or a picture scale, comparable statements, those kinds of things, right? Clinicians, including psychologists, often use the categories of mild, moderate, or severe pain to simplify communication between patients and healthcare professionals. Excuse me. I think I'm trying to get sick. Next category, aggravating and alleviating factors. Okay, so what are the factors that make it better? That is alleviating factors. What are the factors that make it worse? When I bend over, it gets worse. Or, all of those things. Biological factors will include things like age, existing medical conditions, maybe medications the patient's on, genetics of the patient. Social factors would include cultural beliefs, social support, where the injury took place, ADLs, right? Activities of daily living. Psychological factors include like stress, coping mechanisms, maybe the patient's beliefs about their pain, their mood, their expectations, all of those things. Alleviating factors. So a typical question might be, again, what makes the pain better? Right? Is analgesics, yes. But what about non-pharmacological approaches? Maybe they haven't thought of it. We'll try massage, relaxation, music. Visualization therapy helps a lot. Biofeedback, heat and cold application, nerve blocks. These are all common interventions that help relieve pain, right? Then we have physiological indications of pain include you guys already know that, physical factors, right? And then biological factors would be like age, existing medical conditions, and then let's see, pain behaviors can be verbal, verbal descriptions of intensity, location, quality, vocalizations, or it could be distress, moaning, complaining, effects of pain on activities and lifestyle. So we know chronic pain can disrupt people's daily routines and activities. It could include things like cooking, shopping, housework, gardening, do it yourself, all of these things, right? And it can lead to patients just literally not enjoying or doing much in their life, right? Periodicity of pain, which is it intermittent? Is it continual? Is it brief? Is it transient? All of those things, right? So intermittent, does it come and go? Prolonged, does it last continuous, right? Nonstop. But again, remember, pain can interfere with normal movement and it can lead to mobility issues, and this is why we need to address it and treat it. Okay, basic methods of assessing pain are listed here, and you can see that there are many ways to assess a patient's pain. However, be careful with the report of a family member or a person close to the patient. We can use this to alert us to an assessment, but the pain must be assessed from the patient's perspective. So if we're at the nurse's station or we're on the floor caring for another patient and a family member comes up and says, my mother is having pain and needs a pain pill, not a problem. Go into the room and literally assess it from the patient's perspective. Based on what the patient says, we will grab the appropriate pain medication at that time, right? If the patient can speak and is cognitive, then they must be the one to tell you what their pain is. End-of-life patients can have pain medications ordered much more frequently than we do in the hospital, such as every hour, or I've even had them every 15 minutes where I'm giving both opioids and benzos to make the patient comfortable, right? They, end of life, require much more frequent assessments and will possibly require the nurse to use physiologic as well as non-verbal parameters for assessing pain, right? We need to, as a nurse, before it even happens, we need to identify pathological conditions or procedures that could bring upon pain so that we pre-medicate for the pain, like we discussed with wounds last week, right? or the week before. And so we are going to pre-medicate a half an hour before we come in to do a wound change, dressing change. That's painful, right? You're going to consider the physiological measures like increased blood pressure, increased pulse, increased respiratory rate, all of those things. We're going to look at nonverbal behaviors like a patient's getting restless, if they're grimacing, crying, clenching their fists, if they're protecting their body from a painful area, all of these things, right? And we're going to treat them based on those factors. Those nonverbal factors are sufficient documentation in order for you to give a PRN pain medication, right? Any of those: restlessness, grimacing, crying, clenching their fists, moaning, furrowing their brow, frowning, all of those, okay? And then again, you're going to see obviously physical or physiological factors in the body in response to the stress, like increased blood pressure, increased pulse, and all of those things, right? So we'll give and treat the patient's pain accordingly, and then of course monitor the patient and the physiological responses to ensure that they have a positive reaction, and bring down the heart rate, all of the blood pressure and respiratory rate and so forth. Okay, so here are the 6 most common pain assessment tools. So take a look at your book. These are referenced really detailed. They have good pain scales in them. You do need to know these pain scales. The numeric pain scale and the Walker-Baker Faces scale are what we use at my hospital. It was widely used with people of ages 3 and older, and not limited just to children. This self-assessment tool must be understood by the patient. That's a key component. So you need to do education on the scale itself before asking them to rate their pain, so that they're able to choose the face that best illustrates the physical pain they're experiencing, right? The Wong-Baker Faces Pain Scale is a self-assessment tool, again, that can help people communicate about their physical pain. It uses a combination of faces, numbers, and words by providing multiple ways for people to express their pain. The Bayer-Oucher Pain Scale is a poster developed for children to help them communicate how much pain or how hurt they feel. There are 2 scales on the Oucher. It is a number scale for older children and a picture scale for younger children. The Cries Pain Scale is characteristics of crying, oxygen requirement, changes in vital signs, facial expressions, as well as sleep state. You score them, and a maximum score of 10 is possible. If the Cry score is greater than 4, a further pain assessment should be undertaken, and an analgesic administration is indicated for a score of 6 or higher. The FLAC is a behavioral pain assessment scale used for nonverbal or pre-verbal patients who are unable to self-report their level of pain. Pain is expressed through the observation of 5 categories, including face, legs, activity, crying, and consolability. FLAC is a behavioral pain assessment scale used for these patients. Again, Comfort Scale provides a pain rating between 9 and 45 based on 9 different parameters. Each is rated 1 to 5. For example, alertness, 1 for deep sleep, 2 for light sleep, and so forth, right? Then we have the Visual Analog Pain Scale is a tool that dispenses with numbers for measuring pain. It recognizes that many patients don't experience pain in discrete units like numbers, but in a variable way that exists on a sliding scale. A pain visual analog scale allows patients to mark their pain intensity on a continuum. Most are straight lines of a fixed length, though some can have middle points or metered shape scales. Okay. I wouldn't focus too much on the kids one. Kids scales, I would more know, other than the Wong-Baker Faces, because we do use that sometimes for our elderly patients. So Wong-Baker, visual analog, and the numbered scale, and all of the scales not relevant to peds. And go again into your book and look at them, okay? Because the book has great examples in there. Okay, most patients with pain feel better, suffer less, and experience less anxiety when they believe that a competent nurse cares about their experience of pain and is available to help and support them. Without the confidence developed in a good nurse, patients' relationships, nothing seems to work to cover their pain. So be aware of that, right? It starts with us. I have experienced this. Patients have better outcomes and call for pain medication less when they believe their nurse is proactive in keeping their pain under control. I have had numerous patients request pain medications from me less often because I make a plan ahead of time with the patient. I have received a report from a nurse that told me that patients were on their call light all day asking for pain medications even before the medication was available to be given to them. So I went proactively into my patient's room at the beginning of my shift, and I go over with them the doctor's order for pain medications, how often it's ordered, and I educate them on each of the medications that they have available to them and what they're indicated for. I actually write the schedule on the board when they can have it, and we make a goal of staying ahead of the pain. It is so much harder for any nurse to chase pain. Okay, so when we say chase pain, we literally mean when a patient's pain is not managed and it gets out of control, it becomes almost impossible at times to manage it. So you really want to stay ahead of the pain, okay? I ask my patient if they want me to wake them up for pain assessments because some of them don't care that their pain is managed and they want to get sleep. So we always ask them that, okay, do you want to be woken up so that I can assess your pain and give you your pain meds, okay? This way I can keep my assessments consistent and keep the medication coming, right? And keep their pain managed. If they say no, I do educate them though on what happens if they skip pain meds. They could get, their pain could get out of control and it could be difficult to manage, okay? Once the patient knows I am going to come in to assess them based on their ordered meds and they can see the schedule and they can see we're on top of it, they no longer feel they need to set an alarm or alert themselves when their next pain dose is due. It's literally right in front of them on their board, on their whiteboard. Setting up that trusting relationship, providing frequent assessments will put them at ease and then they can relax. And guess what? Their pain, the gate theory, based on the gate theory, will be much less, right? Open, and therefore they won't feel as much pain, right? While having these conversations about pain and pain medication, also have the non-pharm measurements and methods that we use at home to help as well, right? They may be aware of several that work at home, and we are going to implement them, like music, heat, cold, application, pillows for positioning, massage, aromatherapy, all of those things, right? We're going to still do them in the hospital too, and we're going to encourage them to do them as well. Okay, manipulating our patient's pain experience, okay? How we think about our pain definitely influences it, okay? Our interpretations about pain may increase or decrease pain's perception, as well as our disability toward pain. Our beliefs about pain can increase or decrease its perception and disability of it. Catastrophizing pain will definitely increase the pain's experience on the body. Our negative thoughts about pain or beliefs about pain may increase the pain and the amount of disabling pain that we expect, that we have. So our expectations may influence our actual pain perception and our disability. Remember, pain is a subjective experience, and although it is certainly related to physiological processes, how patients react to new episodes of pain is shaped and influenced by their previous experience. Indeed, without learning from experience, it would be difficult to cope with pain and maintain good health. So these psychological processes have tremendous value for survival, right? and they can help remove and alter our cause of pain, right? Our experiences. They can also alter factors affecting our pain tolerance. And it is important to initiate both non-pharm and pharm measures to help relieve pain. One thing we never, ever, ever want to do is to use what's called a placebo or a fake medication to manage pain. It is unethical. It creates an environment of distrust. It can cause our patient to feel foolish. It can result in disruptive behavior from the patient. It will definitely result in litigation. And it can actually result in harm to the patient, okay? So never, ever, ever, ever lie to your patient, because when you give them a placebo, that is a lie. Vigilance may increase the pain intensity, so we don't want our patients to be totally vigilant and obsessed about the pain. Distraction decreases a patient's pain intensity, so we want to distract them, right? Get them onto something else. Patients' interpretation and beliefs about the pain, again, can either intensify it or it can lessen it, right? Catastrophizing, though, will always increase pain. Let's see. Fear may increase pain. Avoidance behavior may increase pain, right? Anxiety will increase pain, and pain's disabling behavior. Same thing with depression. It'll increase pain. Distress will increase pain. It'll fuel the negative reactions to pain. Positive emotions do the opposite. They decrease pain, right? Right. Non-pharm pain measures. So there are many other forms of pain management in addition to pain meds, right? Creating an environment of relaxation can help decrease pain. It can simplify things. You can do things like turning on a movie for your patients to watch, or dimming the lights in the room. Reducing noise helps lower pain. Adding the patient's favorite music, or warm shower, or a warm bath. Humor, right? Imagery. So guided imagery is a mind-body technique, also known as visualization. And it is a well-recognized, scientifically validated way to relieve pain, stress, anxiety, depression. It's driven by the idea that if a patient can envision their pain receding, they can achieve it. And then, so as a nurse, you just literally walk them through a visualization activity, right? Can't say that word today. Visualizing, their favorite place, right? Relaxation. A relaxed nervous system is less likely to notice pain or communicate those pain signals to the brain. So we definitely want our patient relaxed. Our brain also associates physical relaxation with peace and comfort. Cutaneous stimulation involves stimulation of nerves via skin contact in an effort to reduce pain impulses to the brain. Remember, based on the gate theory of pain, a device is used to provide electrocutaneous nerve stimulation. This was studied to see how it would positively or negatively affect symptoms of, for example, peripheral neuropathy. And they figured out that the electrocutaneous nerve stimulation actually helps. Acupuncture. What is pain management via acupuncture? It involves the insertion of thin needles into the skin to stimulate the nerves, the muscles, and the connective tissues through the body with the goal of alleviating pain, alleviating tension, and alleviating stress. More broadly, acupuncture is actually a family of different procedures, right? And again, they go in and they insert these tiny little needles. You can't hardly feel it. And it helps alleviate pain, stress, and tension. Hypnosis is a changed state of awareness and an increased relaxation that allows for improved focus and concentration. We refer to it as hypnotherapy. It's usually done with the guidance of a healthcare provider using verbal repetition and mental images. It isn't about convincing the patient that they don't feel pain. It's about helping the patient manage the fear and anxiety that's related to the pain. It'll relax the patient and it redirects their attention from the sensations that they're feeling of pain. Biofeedback. Okay, during biofeedback, the patient's connected to electrical pads that helps get information from their body. They may not realize it, but when the patient has pain or they're under stress, their body changes. Their heart rate increases, they breathe faster, their muscles tighten. So doing this biofeedback method helps relax all that. Therapeutic touch uses a practice called laying on of hands. So what they do is to correct or balance the energy fields. Despite the use of the word touch, the hands usually hover over the body and don't actually physically touch it. But what they do is they hover over the body and they use the energy of their balance energy to help do therapeutic touch for the patient. So therapeutic touch is based on the theory that the body, mind, and emotions form a complex energy field, right? And therefore it helps positively affect that energy field. Animal facilitated therapy, also known as pet therapy, one of my favorite things, entails using trained animals to provide some sort of therapeutic benefit. We see all kinds of things from comfort, relaxation, complete easing of the patient's pain. This works for people of all ages with a wide range of health problems, okay, including end of life, and we'll talk about it more when we do hospice and palliative in the future. Pharmacologic pain management is a complex process that requires adequate assessment, consideration of guidelines and regulations, knowledge of medications, sufficient tracking and follow-up, patient teaching, and an interprofessional approach to make informed decisions and individualize patient care. We, as nurses, need to have updated information and ongoing education about drug therapy, the cornerstones of pain management regimens, things that work, things that don't, and so forth. I joined the Pain Champion Committee when I was a new nurse on my unit. I learned a lot about pain management. We had our palliative care physician come and speak about pain management. We learned so much that day. Part of our responsibility of being on this committee, we were responsible to take information we learned about pain management back to our units and our colleagues, and to teach our colleagues about pain management techniques. And it was a really great experience. And honestly, as a result of that, our ability to manage our patients' pain was positively impacted from there on. Generally, our goal in an acute care setting is to return the patient back to their baseline. Therefore, our goal is to control pain during the acute phase and then wean them off if they do not use medications prior to their admission. If they live with chronic pain, then we want to return them back to using the medications that they used prior to this hospital admission stay. Generally, doctors order an oral narcotic and an IV narcotic for breakthrough pain. The idea is to control the initial severe pain with the IV medication, and when they can take oral medication, switch to oral meds for pain control. If the oral pain medication does not control the pain until the next available administration, then the IV medication is available for breakthrough pain. If you don't provide frequent ongoing assessments, then their pain can get out of control and you may never get it under control, okay? So again, if you don't do frequent ongoing assessments, you may be always having to use the IV medications to control the patient's pain. So it is normal for you to do IV and PO pain medications every other, right, to manage a patient's pain, especially initially when the pain is much, much worse. We'll talk more about this in class, okay, because it's important. Adjunctive analgesics help control pain by controlling issues that can increase pain that are outside the indication of pain medication. So this includes things like corticosteroids that helps reduce inflammation, because inflammation causes pain, right? And narcotics don't have an inflammation reducing property. So they don't work on the inflammatory pain. So you got to know what type of pain you're treating so that you grab the right medications, right? That's why we got to get the qualifying and quantifying factors from the patient. Depression causes pain. So again, opioids aren't going to help with that, but antidepressants will, and therefore that would be an adjunctive therapy, right? So some commonly used adjunctive pain medications include antidepressants, anticonvulsants, local anesthetics. We're doing a lot of ketamine infusions now. Corticosteroids, biphosphonates, all kinds of stuff, right? What else do? We do calcium channel blockers, lidocaine. Oh my gosh, how could I forget lidocaine? Capsaicin, tramadol. Again, find out it's important to ask the patient what has worked well for you in the past, because everybody's chemical balance is different in the body, right? And why wouldn't you want to ask your patient what's worked well for them in the past? Of course we want to know that, right? The WHO 3-step analgesic ladder. So in an effort to alleviate unnecessary pain and suffering, the World Health Organization devised a 3-step analgesic ladder that recommends the appropriate progression of drugs and dosages that should be used to manage chronic pain effectively. Emphasis is on individualizing treatment and using the analgesic ladder to provide attentive, aggressive pain relief. Its 3 steps are: step 1, non-opioid plus an optional adjunctive analgesic for mild pain. Step 2 is a weak opioid plus a non-opioid and an adjunctive analgesic for mild to moderate pain. And step 3 is a strong opioid plus non-opioid and an adjunctive analgesic for moderate to severe pain. The WHO pain ladder describes pain in terms of intensity and recommends that analgesics be prescribed starting at step 1. Right? So again, non-opioid analgesics like acetaminophen, non-steroidal anti-inflammatory drugs or NSAIDs. If the pain persists or worsens, the clinician prescribes pain relievers from step 2, described as weak opioids, with or without a non-opioid or adjunctive therapy. So at this point, if pain persists or worsens, the patient will be administered a strong opioid with or without a non-opioid analgesic. Thus, pain therapy is based on pain intensity, and patients progress through steps 1 by 1 from lowest to highest until pain release is obtained. The term weak and strong opioids are hardly used today, but are readily understandable. So even though we don't talk strong and weak opioids anymore, it is useful to speak in these terms when we're talking about the WHO analgesic ladder. Okay, so under the analgesic ladder, the World Health Organization lists codeine, hydrocodone, and tramadol as weak opioids, and morphine, oxycodone, methadone, hydromorphone, and fentanyl as strong opioids. Okay? Write those down. While the WHO pain ladder is imperfect, the same could be said of any one-size-fits-all approach to pain. But the brilliance of the pain ladder is that it works, and it works well most of the time when used as intended. Okay? The Pacero opioid-induced sedation scale can be used to assess respiratory depression in adults and pediatric populations. If respiratory depression is suspected and the next opioid dose is withheld, the patient may be physically stimulated by shaking or using a loud sound, along with reminders every few minutes to breathe deeply. If this is ineffective, naloxone, an opioid antagonist that reverses the respiratory depression effect of the opioid, can be used and should be used. Naloxone, if administered intravenously in the hospital setting, so again, we administer naloxone as an IV in the hospital setting, but there is a new form, not new, but there is a form that is used intranasally that a lot of us carry a lot around in the environment, because you come across people who have overdosed, especially in larger cities, right? Usually within 1 to 2 minutes, the patient will open their eyes and they're able to respond to the nurse, right? Because what happens with naloxone is it goes in and it kicks off the opioid medication that's bound to the sites, and therefore the patient can no longer get, they're not getting overdosed by that med, because the naloxone is now kicks off on that mu receptor, right? When the patient is alert, again, and the respiratory rate is greater than 9 breaths per minute, the opioids can be resumed, right? So just be careful, but it's got to be above 9, right? And if it's below 12, really, you should be thinking, do I really give this opioid dose, right? It's a conversation that needs to be held with somebody, doctor, somebody in maybe a charge nurse, right? Okay, so take a look, pause the video, look through this sedation scale. I'm not going to read through that. Okay, pain management regimens for cancer or chronic pain patients. Okay, nearly half of cancer patients experience pain. Cancer pain can be a presenting symptom that leads to the diagnosis itself, or it may only be felt in the late stage of disease. Many cancer patients do not experience any pain associated with their cancer. Half, in fact, right? For those that do, it can be mild, moderate, or severe. Since each patient's cancer pain is unique, treatment plans for pain management should be tailored to that individual's needs. Causes of cancer pain come from different sources. There are pain from tumors. Most cancer pain occurs when a tumor presses on a bone, nerves, or organs, right? And the pain level will be stemming from that, right? It could be treatment-related pain. So, for example, chemotherapy, radiation therapy, or even surgery can cause pain, right? Certain painful conditions are more likely to occur in patients with a suppressed immune system, which is often a result of these therapies, right? If you're getting chemo and radiation, or if you're being put under and surgically, worked on, you're obviously going to have your immune system's going to be suppressed. Postoperative pain obviously is definite factor. So relieving pain resulting from surgery helps people recover more quickly and heal more effectively. So it is our job to manage a patient's post-op pain. Treating cancer pain. So cancer pain, again, is very treatable. About 9 out of 10 cancer patients find relief using a combination of medications. Some medications are general pain relievers, while others target specific types of pain and may require prescription. Emphasis is on individualizing their care and using the analgesic ladder to provide alternate aggressive pain relief. Movement through the analgesic ladder may not always progress through all steps in an orderly fashion, because depending on the intensity of the patient's pain, we may need to skip one of those steps, right? Or rather move quickly through it. Ladder is not always appropriate. As clinicians will develop plans for each individual, this will need to be closely monitored and assessed for changes along the way as well. Giving medications orally, if possible, is always the goal. We want to give long-acting medications orally and administer medications around the clock. for cancer patients and chronic pain patients. I cannot stress this enough. You want to manage pain around the clock. This means if you have a patient who only has a PRN order for pain meds and they're a cancer patient or a chronic pain patient, something is wrong. You need to have a conversation with the doctor and get the patient on meds around the clock. You want to administer medications, again, adjust the doses to achieve the maximum benefit with the minimalist of side effects as possible. We want our patients as much control as possible over their pain regimen. We want to provide short-acting medications of the same type as needed for breakthrough pain. Our dose typically should be about 25% of the long-acting dose. If 2 or more PRN doses are needed in 2 or more days, then we need to increase the long-acting dose. Let me repeat that. If any nurse have used 2 or more PRN doses in 2 or more days, then the long-acting scheduled around the clock dose needs to be increased. Okay, mild to moderate pain. So again, when we talk about non-opioids, we're talking acetaminophen or NSAIDs, aspirin even, right? Ibuprofen, those kinds of things. And we can get those over the counter. And they're adjunctive therapy and they help, right? So don't forget about the fact that those will help as well, right? And then we have our opioids again, examples: morphine, hydromorphone, oxycodone, hydrocodone, codeine, fentanyl, methadone, endless, right? We have tingling and burning pain, like neuropathic pain, right? We also have antidepressants that are used for depression pain, like amitriptyline, trazodone, doxepine. Remember, taking an antidepressant doesn't mean the person has a mental illness, right? Because they could be using it for pain, right? We also have anti-epileptics like gabapentin, right? So for neuropathic pain, right? Taking an anti-epileptic, again, doesn't mean that they're going to have a seizure. They could be taking it for pain, neuropathy pain. Let's see, pain caused by swelling, those kinds of things. We also have steroids, right, that we give for pain, right? Inflammatory pain. So this includes prednisone, dexamethasone. Those are great for reducing the inflammatory response in the body and therefore reducing inflammation pain. Non-drug cancer pain treatment. Again, even though they have cancer, we may recommend non-drug cancer drug type of pain relief. But remember, that's adjunctive. It should not be used in lieu of the opioid pain meds because cancer patients need opioids typically. Biofeedback, again, is a technique that makes the patient aware of their bodily processes, often considered involuntary, like their blood pressure, skin temp, heart rate, respiratory rate, all of those things, right? Once the patient becomes aware of it, they can gain some control over these processes, which definitely can influence positively on pain levels, right? Breathing and relaxation techniques and exercises can help focus the patient's attention on a specific task instead of concentrating on the pain, so that helps lessen the pain. Distraction, again, a method used to shift attention away from the pain to a more pleasant event, object, situation, will help lessen the pain. Heat or cold application, using temperature to control pain, definitely works, right? Using cold packs or heating pads, those kinds of things. Hypnosis, again, is focusing on a state of consciousness that allows the patient to better process information. Imagery uses soothing, positive mental images that allows the patient to relax. Massage, pressure points, vibration, physical stimulation of the muscles or nerves, all of these can help relax and relieve painful muscle spasms or contractions. We have TENS units, which is the transcutaneous electrical nerve stimulation units that gives a mild electrical current, through the skin at the site of the pain that helps dole out the message from that's sent to the brain. Acupuncture, where providers insert fine needles into the skin that stimulate small electrical currents that help decrease pain. Cognitive therapy, that's like psychotherapy that helps patients by changing the way they think and feel about things, right? That can help with pain too. Pain treatment in special populations. So now we're going to talk about older adults. So, as you already know, we've talked about every single body system in decline in an elderly patient's body, which you definitely need to know, right? The majority of our elderly suffer from chronic pain that significantly alters their daily activities and imposes enormous burden on the healthcare system, right? Multiple comorbidities and the risk of polypharmacy in the elderly make it challenging to determine the appropriate drug, dosage, and maintenance of therapy. Pain is often undertreated in the geriatric population for a number of reasons. First, many providers and patients hold the misconception that pain is an expected and natural consequence of aging, when in fact it should not be looked at as of that. Second, many elderly patients have physical impairments such as visual, hearing losses, even cognitive impairment, which could include confusion, memory lapse, or dementia type, interfering with, clear communication. Third, concerns of either the provider or patient regarding the side effects of opioids, including respiratory depression, addiction, falls, is huge. Having that often creates a barrier to indicated therapies. Fourth, because of the magnitude of medications typically used by the elderly in treating a variety of other medical conditions, there's a concern about drug-to-drug interactions and polypharmacy. And finally, the patient often underreports pain because of the fear that it may represent impending death, loss of autonomy, or, further testing and treatment. Fortunately, healthcare providers can better understand the unique aspect of pain control in the geriatric population and, as a result, greatly improve the patient's quality of life. Both hepatic and renal function are decreased in the elderly, thus resulting in a decrease in the ability to metabolize and eliminate any medications that we give them. This places the patient at an increased risk of toxic side effects of pain medication. Aging affects the absorption, distribution, metabolism, and clearance of medications. So how will you manage pain in the elderly patients? So for patients with mild pain, you want to try non-opioid medications, right? So try acetaminophen first. Or in very healthy patients, you can consider NSAIDs, right? But acetaminophen, again, is a great medication to use. Remember, with the elderly, I would not advise giving more than 3,000 milligrams per day. And then in a healthy younger adult, they can have up to 4,000 milligrams per day. For moderate or severe pain, opioids are appropriate for the elderly, but consider a lower dose than younger adults and place patients on a monitor to pick up any respiratory depression or hypoxia, right? Non-pharm interventions, so all older adults should be considered non-pharmacological interventions as well, right? These include the behavioral therapy, exercise, occupational therapy, physical therapy, use of assisted devices. We might even include weight loss with them, right? Anything that can help improve activity and ADLs and all of that, right? So some of the challenges with the older adult population, again, could be communication difficulties. They may not be able to quantify or give very descriptive pain, like the quality or quantity indicators or how the pain started. They may not be able to give you a full chronological order of it. It is a myth that growing old is supposed to hurt. And many people believe this, right? And so we need to talk to patients and let them know that that is a myth and you don't need to deal with that kind of pain, right? You are not supposed to hurt, right? And then it's important to remember that, remember we talked about how everything slows down, including the GI motility, right? So we know that because the absorption, excretion, and GI motility all slow down, meds stay in the GI system longer. So slow GI function may cause delay in absorption too, right? Okay, additional methods for administering analgesics. So we have patient-controlled analgesic pump. It's a computerized machine that gives a drug for a pain medication through a little controlled analgesic, and the patient just presses a button, and it will deliver a pre-allowed programmable dose, and then it has a timeout function though, just so everybody knows they can't overdose, right? So for example, if the patient can get 1 milligram of drug X every half hour, then if they were to press it, 14 times at half an hour, they're only going to get 1 dose. Okay, so it times out. So again, it's a machine that gives the patient a dose of a pain med when they press a button. In most cases, PCA pumps supply opioid pain controlling drugs such as morphine, fentanyl, hydromorphone. The machine may be delivered, they may be delivering a continuous dose, which is what we call a basal rate dose. So it's continuously giving a scheduled amount all the time around the clock, or it could be either. It can also allow the patient to press the breakthrough dose, or what we call a bolus dose, okay? But remember, it has a timeout function and won't give the patient an extra dose if it's not time. Remember, no one should press the button on the PCA pump except for the patient. This includes the nurse, okay? So, again, nobody other than the patient should be pressing that button on the PCA pump. So it's important that the patient is alert and oriented and able to control this. And if they're not, then they really shouldn't be using a PCA pump, okay? So you'll see these pumps sometimes after surgery, many times for chronic pain patients, and then of course at end of life sometimes, because they can be more effective at controlling pain around the clock. We still need to assess pain every 4 hours and more frequently if needed, so that we can treat any uncontrolled pain. Epidural analgesia is the most popular method of pain relief during labor. Epidural analgesia is a regional anesthesia that blocks the pain in the particular region of the body. The goal of epidural is to provide pain relief, which leads to total lack of feeling. The epidural blocks the nerve impulses from the lower spinal segments. This results in decreased sensation in the lower half of the body. Not complete elimination of sensation, but a decreased sensation, right? So again, a small tuber catheter is threaded through the needle into the epidural space. The needle is then carefully removed, leaving the catheter in place to provide medication either through the periodic injections or by continued infusion. The catheter is taped to the back to prevent it from slipping out. Local anesthesia is used to numb the feelings in the specific part of the body. Again, this prevents pain during surgical procedures. The anesthetic drug is applied to the part of the body that is undergoing the surgery. It may be used with sedation, which calms the patient and reduces their stress level. Together, they enable the surgeon to carry out the procedure without pain or distress. Local anesthesia only lasts a short time, and it places the patient under rather quickly, right? So it is mainly used for minor outpatient procedures where the patient can leave on the same day. Local anesthesia is used when surgery is minor and does not require general or regional anesthesia. The procedure can be done quickly and the patient does not need to stay overnight. This could be like dental surgeries, maybe to remove a mole, cataract, biopsies, those kinds of things, right? Make sure that that you do all of the medication template for this week's medications, including morphine, naloxone, temazepam, zolpidem, and diphenhydramine. There will be at least one exam question on these medications this week, and they are important, and you will use all of them quickly and frequently. So make sure you know them. We're also going to talk about ranking of opioid medications in class, so that you have a good understanding of the mild to, strong opioids. Patient-controlled analgesia. Again, we talked about this pretty significantly. This allows the patients to control the administration of their own medications with predetermined safety limits. Can be used with oral analgesic agents as well as with infusions of opioid, intravenous, subcutaneous, epidural, or pre-urinal routes. Okay, so you can give patient-controlled analgesia a multitude of ways. I've literally given it into subcutaneous tissue on my patients in their abdomen before hospice patients. So if there's a route, you can get a med in it. Okay, just about anything. It can be used to manage acute and chronic pain. It can be used in any healthcare setting or in the home, right? I've told you we can do it in the home. We do it all the time. Okay, last slide, teaching about pain. Obviously, educating about pain is big, right? Because pain's perception in an environment is wrong many times, right? And it is important to include family members, caregivers, friends, anybody that's going to be involved in that patient's care, as long as the patient agrees to it, of course. We got to explain the pain scales in detail. We have to explain safety things like not driving when the pain medication affects their neurological status, right? So up to several hours after taking their pain medication, don't operate any heavy machinery. Don't drink alcohol while taking these meds. Don't take other CNS depressants like benzos with these meds unless their physician has approved it. They need to be careful and understand that it increases their risk of falls for some patients, right? They need to keep a diary of their pain and medications that they've taken, just in case they forget, right? Because they can overdose real quick if they don't. So we ask our patients to keep a diary. It's important that patients not breastfeed with some pain medications. Now, what I'm going to say about that is this. Some pain medications, even some opioids, are fine to take with breast milk. Some are not. We do not cover this part in block 1, so I'm not going to go into that detail. You'll cover it in block 3 and block 4, both 3 and 4. So again, you don't need to know the breastfeeding piece of it. Just be aware that some are safe and some others are not, and you'll learn about those later on. Okay, that's it. This is the end of the chapter.